And myself, Mohamed Azim, consultant ophthalmology in Al Ain Eye Center. We'd like to start right away. Today it's going to be more or less basic. However, it's going to be a little bit dry because there's no real cases. It's not clinical. So I hope you bear with us. We start with Dr. Dina. Dr. Dina, can you start?
Yes, thank you for the introduction, and thank you to everybody who is with us. Let me open my presentation real quick,
You
and we'll be on
share.
the way. Yeah. Good. Okay.
Are you able to?
Okay.
Share
Yeah.
screen? Yeah.
Yeah. Okay. So we're on, right? Perfect. Can you all see my screen now?
That's perfect.
Good. Okay. So I'm Dina Baddar. I'm a consultant ophthalmologist who works in medical retina and uveitis in Egypt. I want to start taking you through the journey of a patient. I'll be taking you together with my co-presenters to this uveitis. It's a very challenging subspecialty, but let's try and break it down for everybody so it becomes easier. So what we're trying to do is divide the uveitis entities as much as we can into anterior, intermediate, panuveitis, and infectious uveitis. Why do we do that? In order to identify the pathognomonic signs and to minimize the lab orders and eliminate confusion in the office. The thing is not to completely not order any labs. It is not right. We depend on labs. We do baseline labs in order to follow up the patient. We do also baseline imaging, but it's complementary. It's not the only thing that we do in clinic is order labs. No, it complements your clinical judgment. So why do you need to differentiate? Because chronic diseases are chronic. You know, nature of the chronic disease is that it goes away once you start withdrawing it goes away when you give treatment. It flares up when you reduce treatment. And if the patient is completely uh, inflammation free, you don't take the treatment completely away. You keep the treatment. And follow up is required even in the absence of symptoms. I do not need to stress this. Systemic disease needs collaboration. So if you're going to work with the rheumatologist, going to work with the pulmonologist, a pediatric rheumatologist, even refer to an anterior segment surgeon. If you're not trained to do anterior segment surgery or posterior segment, it really depends on your patient. But what we're trying to say is collaborate, because this is all for the good of the patient. It doesn't mean that you don't know much. It means that you know your part really well. It's just that you're guiding the treatment for the systemic for the systemic good of the patient, you know. So on the first visits, and I think Dr. Abdel and Dr. Kamal will agree with me that the first visit is usually the longest visit. You take a detailed history of the disease, you examine and all the documents the patient comes with, every single document, even if it doesn't pertain the eye, even if it's a CT, an MRI, a PET scan, whatever it is, you look at it and you document everything that you have, because you might need it later in the course of the disease, you know. So you don't, first of all, you don't order too many. Second of all is to always keep going back to your diagnosis. You know, you need to be very flexible with uveitis. If you think that the diagnosis is not fully what you think it was, it's okay to go back to whatever uh, uh, baseline that you have and rethink your diagnosis. Review all the symptoms. Do not take no for an answer. Keep probing the patient. You know, patients don't usually think that it's significant to mention skin rashes in an ophthalmology visit, but it is. Determine the primary region of inflammation. So at least in the first setting with the patient, you need to determine at least where the primary region of inflammation is, so that you direct your thinking. And if you have inflammation in the anterior segment, it's okay to use drops. However, we would recommend reducing systemic treatment until you know what exactly you're working with. Okay. So again, this is the scheme that I would like to draw the attention of everybody to in anterior uveitis. If you have systemic illness, you use systemic treatment. Okay. Not only you, you collaborate. But if there's no systemic illness, it's okay to use topical treatment, even if chronically so. What about intermediate uveitis? If it's unilateral, it's okay to do regional steroids and it's okay to do surgery. If it's bilateral, then you always consider going systemic. Okay, do regional steroids to augment the treatment, the systemic treatment that you're using, and also consider surgery if the complications or the inflammation is too much that it's obscuring vision or obscuring your ability to see the fundus. With panuveitis, if you have systemic illness, use systemic treatment. If you don't have systemic illness, also use systemic treatment. Okay, so couple of clinical cases. This is a 43-year-old male, long history of ocular inflammation of undecided origin. He has granulomatous anterior uveitis. You look at the skin, there's vitiligo, there's perilimbar vitiligo, what we call the Segura sign, and he has thickened choroidal OCT. This is probably Vogt-Koyanagi-Harada disease. A first encounter of a 37-year-old male with a long history of ocular inflammation, again, undetermined reason, chronic anterior uveitis, nothing in the posterior segment. This is but he has the deformity in his hands. This is probably chronic anterior uveitis associated with leprosy. First encounter with 32-year-old male. He has those scaly skin lesions in places of contact. This is granulomatous with granulomatous intermediate uveitis. This is psoriasis associated intermediate uveitis. And the reason why I want to stress this whole, determine what exactly you're dealing with is because it's very unsafe to use systemic steroids, for instance, on psoriasis patients, because systemic steroids cause a flare of psoriasis after withdrawal. So when you're using systemic steroids, the patient is doing well, but once you withdraw the steroids, the patients can get a severe flare up of psoriasis up to pulmonary psoriasis. So it's a serious condition. A first encounter of an 18-year-old female with posterior scleritis. She has those skin lesions that are macular, that are more necrotic in nature. This is GPA, what we used to call Wegener's granulomatosis, but it changed name to granulomatosis with polyangiitis. Also, this is what we were saying about flexibility, So along the course of the treatment, this is a patient who was under treatment for anterior uveitis. He was only on drops. And then along the course of the treatment, he developed this granulomatous inflammation of the skin and also posterior segment vasculitis and macular edema. This patient was biopsied and was proven to be sarcoid. So always be flexible. Now, when we talk, we're going to go through with the main findings in each entity. This classification, we're going to go anatomically, really. So, anterior uveitis, it's either going to be iritis, iridocyclitis, or cyclitis. So, it basically the source of inflammation is the anterior segment. Even if you have some cells that are behind the lens, it's okay. We still consider this anterior uveitis. It's okay to give topical treatment for these patients. So the acute signs, we all know, like limbal injection, photophobia, plus or minus hypopia. Often the intraocular pressure is low, the cells more than the flare. This is acute. While the chronic patients are usually, they give you a long history of treatment. They're sometimes on drops, sometimes they're off drops. They can't really determine when they stopped the drops and when they didn't. And usually the flare is more than the cells, and the IOP, from the chronicity of the disease. Maybe they have some posterior synechiae, maybe they have iris bombay, but the IOP might be high. In acute cases, the IOP could be high, and this is it's such a famous question in examinations. When do you suspect? What entities do you suspect in high IOP in acute anterior uveitis? Herpes, Boston-Schlossman, in which cytomegalovirus is incriminated in the pathology, toxoplasmosis, or steroids. Now, this is what we all know. The thing is, I've noticed that a lot of people do not really cannot really tell cells from flare. So basically, cells are actually floating little drops in the anterior chamber, while flare is usually turbidity in the anterior chamber. Okay, the signs we all know, the non-granulomatous cases and the hypopyon, small KPs, and Kepi nodules. So Kepi nodules are considered non-granulomatous uveitis, while granulomatous, you remember, you see those mutton fat KPs, whether they're medium size or large. You see sometimes ghost KPs. I hope you can appreciate this image where there's um, ground glass appearance of ghost KPs. So these were KPs that are gone, or Bosaka nodules that are actual nodules in the body of the iris, in the stroma of the iris. The review of systems, I cannot stress the importance of a full review. Um, Joint pains, low back pain, skin rashes, abnormal mucous membrane abnormality. Of course, in our region, we have a lot of Behçet's disease. So mouth or genitalia, episodes of colitis and bowel inflammation, because IBD is often associated with uveitis. General health, fevers, loss of weight, loss of appetite, occupation history, and travel history. Of course, also ask about recent illnesses and recent drug intake. With non-granulomatous uveitis might be more forgiving, but granulomatous is not. So with granulomatous uveitis, you have to be quite um, thorough about your history taking, because if you're looking at granulomatous with polyangiitis, it's a fatal disease. Okay, sarcoidosis. Infections are serious too. VKH is visually debilitating, and sympathetic ophthalmia, because you're looking at a single-eyed patient. You have to be very, very serious about the treatment. So, first attack in the pediatric age group, sometimes we get really afraid of what we're dealing with, but don't be. The most frequent causes are post-systemic antibiotics, post-systemic infections, and post-traumatic. While TINU is very serious. Now that's a non-granulomatous tuberous interstitial nephritis and uveitis. Usually, patients present first with the kidney symptoms and then they develop eye symptoms. There's a patient who had flank pains or a fever of unknown origin or hypertension. So usually they have renal symptoms before they develop eye symptoms. We tested by looking at the beta 2 microglobulin in urine, which usually is not present. They're present in very minimal amounts, but if it's high, that's significant. And then we send patient to nephrology for a biopsy. Okay, just remember these are patients with bilateral acute anterior uveitis. What about iridocyclitis? Now, iridocyclitis, you always think of Fuchs. So, in one eye, you think of Fuchs uveitis. Heterochromia is no longer a major diagnostic criteria. So, usually it's a middle-aged female, early 40s, coming with floaters or coming with visually significant cataract. You ask her about her symptoms mainly and ask her about if she's ever had annoying floaters. They usually do. And in kids, we should always look for GIA. I would like to point out that anterior vitreous reaction, cystoid macular edema, and disc edema may occur secondary to chronic iridocyclitis. So I cannot stress that you always, always, always have to dilate at least one eye. There are questions. Are there questions on the chat, or do I go on?
No, just go ahead.
Okay, I'll go ahead and we'll take the questions at the end. Okay, so the persistent or the chronic iridocyclitis, there's always sequelae, the ocular hypertension or hypotony, and the causes are either in open angle, closed angle, or combined pathology, while hypotony is usually inflammation or atrophy of the ciliary process, and the thing that we all fear is ciliary body detachment. This is what I was saying on Fuchs iridocyclitis. Unilateral stellate KPs, they have this quite significant appearance, and always ask about floaters. Now, do we use steroids on those patients? So, usually, for sure, don't use systemic steroids. You can use topical steroids, but they reduce the symptoms, they reduce the inflammation, but they're not um, a mandatory treatment. What about juvenile idiopathic arthritis? Now, this is a truly visually debilitating disease. By the time we see the patients, they have pancreatopathy, hopefully not affecting the center. You need to document vision really well, you need to document all the findings that you have, a good history of joint disease, systemic workup, and always, always, always with kids, always work with immunology. Do not undertake this huge responsibility on your own. Now, intermediate uveitis is less, it's a bit, it's a point that's vague in uveitis. In intermediate uveitis, the area affected mainly is the hidden area of the eye, the part that we see less. That is the part between the lens, and the retina. So we're looking at the pars plana, that area that we see, not we never get to actually see on clinical examination. That's the part that is most affected by inflammation. So what do we see? First of all, what's the etiology? So the etiology is either pars planitis. Pars planitis is the name that we give for intermediate uveitis of unknown origin. It has a biphasic occurrence, so it's either in the younger ages or in the middle age. So it's either pediatric age group or middle age. When I say pediatric, I'm not very specific. I'm looking at teenage. Okay. Now, it's very important to take thorough history with those patients because sometimes MS, and a lot of the times actually MS is associated with intermediate uveitis. And for those patients, I would totally recommend getting a fluorescein angiogram with thorough examination of the retinal vessels in the periphery, especially the inferior periphery. Now, sarcoid, you get a chest X-ray if you want, but if you have access to high-resolution CT, it's much more accurate, and you get the serum ACE. With IBS, you get a history of mucus or bloody diarrhea, weight loss, fever of unknown origin, and then you order calprotectin in stools and ESR, and if there's any doubt, send them away to gastroenterology. Tino, we spoke about and mascaritis. Again, I can't really stress that we're going to have a whole talk about masquerades, but I can't stress CNS lymphoma, which is more common in older age. When I say older age, I mean 60 and above. You have to think of masquerades.
Dina, I'm sorry to interrupt you, but
Sure.
one of the attendees is finding it difficult to hear. Probably you need to go a little bit higher. I can hear you very well because I'm wearing
Headphones.
my
Okay. And I
headphones.
and I encourage everybody to so I will speak up, but I also encourage everybody
Use a
to
earphone.
yeah, either using a
Yeah.
earphone or like crank the volume up.
Uh,
All right. So with CNS lymphoma, always think of diagnostic vitrectomies. Even if you get a negative MRI brain, um, even if you can't really tell from the fluorescein angiogram whether this is PPV or not, this is intraocular lymphoma or not. Always keep it in the back of your mind, especially in non-resolving granulomatous uveitis in older age. Pars planitis, not a lot of us see the snowbanks. Snowbanks are basically inflammatory debris in the inferior retina slash pars plana. Sometimes you see it, sometimes you don't. Don't sweat it. It's always recommended to do indentation if you're trained to do it. If you're not, then use uh, uh, a contact lens. Snowballs, we see them a lot, and haze. Like haze is something that is quite vague. So that what I always tell trainees about haze is that basically you're trying to get a focus on the retina, but you can't. This is what haze is. You're trying to focus on the retina, but this is exactly what haze is. It's like turbidity in the vitreous. Good dilation cannot be stressed enough. Now, panuveitis, when you say panuveitis, and I get a lot of referrals that say panuveitis, this is the differential diagnosis of panuveitis. So you're basically cornering yourself in sarcoid, Behçet's, VKH, sympathetic ophthalmia, and infection. When you say panuveitis, the differential diagnosis is very narrow, although it's right. I just believe that it's very narrow, and for me to label a patient panuveitis, I have to have lesion in the back of the eye, whether in the choroid or in the retina or in the blood vessel. I'm going to point out just the herpetic type because it's really visually debilitating. Now, the ARN and the PORN are, they do occur. We see them in the cytomegalovirus. We see them. I'm just going to let the pictures speak for themselves. These are occlusive vasculopathies, both of them. You know, the PORN is more in the periphery, and I actually think those. Okay, hang on. The PORN is in the periphery. The ARN affects the center. I think the images are switched here. I'm sorry. No, I think the images are right. Because the ARN, they have a more circumferential spread and the borders are discrete. What about retinal vasculitis? Now I have a thing with retinal vasculitis. I'm gonna just touch upon it. Oh, where are the images? Okay, can't find the images. It's okay. I promise you I'll get the retinal vasculitis images next time that we meet, hopefully next week. And like, before I give the floor to my co-speakers, let me just say that chronic disease requires close follow-up, and that the multi-system disorders dictate a multidisciplinary approach. The detailed history will point to diagnosis, and infections need special attention. Now, I know I have the vasculitis somewhere, and here they are. I'm just going to say a few things about vasculitis. So you sometimes see occlusive vasculitis with not a lot of inflammation, but sometimes you see a lot of inflammation with vasculitis. What I want to say is that if you see this occlusion, this is usually you know, like Sussex or embolic or systemic lupus. You know, you think of those things, but when you see an inflammation, now you think more of Behçet's, of ANCA associated vasculitides, of infections, and in all cases you should work. You know, when you see retinal vasculitis, you have to start thinking about referring the patient whether to neurology, nephrology, rheumatology, according to all the findings. If you suspect retinal vasculitis, I can't stress enough getting a fluorescein angiogram. So easy. This is what I want you to come out with. Anterior uveitis, use systemic treatment in systemic illnesses. Intermediate uveitis, use systemic treatment in bilateral disease. And panuveitis, always consider systemic treatment. Thank you very much, and I'm happy to take your questions.
Thank you, Dr. Dina. Very nice presentation. We'll let the participants ask at the end whether they have any question. I'm going to start. Okay. Now I'm going to run you through the drugs used in uveitis. Before we start, I'm going to show you the members of our immune system. To the left is the innate immunity, and to the right is the adaptive immunity. From all this is the cell that is responsible for uveitis, the T lymphocyte. What happens is in the normal circumstances, the antigen presenting cell, it disassembles the organism, producing the antigen on its surface. And by the interaction of this antigen presented on this antigen presenting cell with the T cell, in the presence of other co-stimulatory receptors, activation happens. When activation happens to the T cell, this means activation of an enzyme called calciurine. What this does is it opens the pores of the cell to calcium, so that there's an influx of calcium into the cell. With hypercalcemia inside the cell, this would trigger the prescription or transcription of genomes. And this would promote the cell to differentiate, become specialized in attacking a certain organ or a certain organism. And then it would proliferate, the cell would proliferate, and it will also produce cytokines. Cytokines are these chemicals that are used. So all this happens here in the DNA, where in the nucleus, where there's transcription of genomes producing the cytokines. It's like the operating room of a war. So these are the cytokines. Some of them are pro-inflammatory, some of them are anti-inflammatory, and the imbalance between the pro and anti that produces the inflammation or the war. So we need to stop this war. Therapeutic options. The first option is steroids. This is our cornerstone. This has been discovered since the 50s. It's a huge discovery. It's produced within the body from the suprarenal gland, and the steroids receptors are almost present in all cells in the body. What happens is the steroid binds to the steroid receptor, and then they form a complex that internalizes inside the cell, and it travels to the nucleus, where it turns on and off the gene transcription, and thereby inhibiting all and activating cells. And it produces that very quickly, and it inhibits all the members of the immune system. So it's like shutting the immune system. The problem is that these receptors are also present in all kinds of cells, including bone, including all kinds of body cells, and therefore there's a lot of collateral damage. There's diabetes, there's osteoporosis, and so on. So we cannot depend on steroids alone. Although it's still, up till now, we depend on it because it's a very fast acting, and it's because it inhibits all members of the immune system. During the world wars, they used chemical like mustard gas. Survivors of this attacks were found to have bone marrow suppression and aplastic anemia. This has gave an idea to the scientists to use this chemicals for treatment of lymphoma patients, and they did that successfully. So the alkylating agents, the common factor in them is that they are electron-rich molecules which have the ability to bind biological molecules. By doing that, it causes inter-strand and intra-strand cross-linking between the two DNA strands. And this would prevent the multiplication of the cell. It will prevent the separation of the strands, and thereby prevent the multiplication of the cell. It will cause eventually apoptosis of the cell as well. The most important one is drug is cyclophosphamide, and to a lesser degree chlorambucil. Cyclophosphamide is being used up till now especially in vasculitis, ANCA-positive vasculitis, to be more specific. And then in the next step, they discovered the antimetabolites. In the late 50s, the scientists found that folic acid is essential for DNA synthesis, and therefore they tried to develop a drug that will antagonize the folic acid and thereby prevent the DNA synthesis. And it was used and up till now is being used as an anti-cancer, and as well as it prevents the multiplication of the immune cells, and is used very commonly especially by the rheumatologists and by ourselves in juvenile idiopathic arthritis. The other most very famous drug as well is azathioprine. Azathioprine is a very important drug that we very commonly use up till now. The drug is when administered orally, when it goes into the body, it will be acted upon within the cell by glutathione into 6-mercaptopurine. This is one of the purine bases that is involved in the DNA synthesis. So the DNA synthesis requires purine and pyrimidines, if you can remember. One of them, 6-mercaptopurine, will be integrated into the DNA and causing a miscoding, if you like. And thereby will prevent multiplication of the cell and eventually apoptosis of the cell. We commonly use this drug. It's relatively safe. It's not very effective as other drugs, but it is safe for moderate uveitis. In 1973, a company called Sandoz in Switzerland, they were researching fungi and the antifungal activity of fungi. And then they asked their employees to collect soil samples. And by chance, they found a sample that contains a new fungus that's called Telipocladium inflatum, and this is cyclosporin A. And they used this metabolite to test it as an antifungal antibiotic, which they found, unfortunately, is not very effective as an antifungal. However, by chance, they found it selectively inhibits T cell by interfering with calciurine enzyme. So this is a great breakthrough because this would selectively inhibit the T cell without causing a lot of collateral damage. And it's very effective drug. It has a nephrotoxicity, which is in most of the cases reversible, and it's drug related, dose related, I mean. And it also causes hypertension, but it's one of our main weapons, and it remains so for like more than 10 years or more. Up till now, we use it a lot. And the turn of the century, the biological warfare started by the research on antibodies against cytokines. With understanding the role of cytokines, they started to produce antibodies and drugs against them. The most studied cytokine is the tumor necrosis factor alpha. However, there's plenty of other cytokines being produced, drug against them, like interleukin 1, 2, 6, and 17, as well as interferon gamma. What happens in uveitis is that there is an imbalance between pro-inflammatory and anti-inflammatory cytokines. And by producing a drug that inhibits one of the pro-inflammatory cytokine, in most of the cases, it's tumor necrosis factor alpha, this would revert the balance back to a non-inflammatory condition. So these are the available drugs. Most of them is anti-tumor necrosis factor. The most important ones are infliximab, which is Remicade. This is a chimeric, which means partly prepared in rats and partly in human. Adalimumab, which is Humira. This is very commonly used now, especially in children. Intercept or Enbrel hasn't been found to be useful at all in uveitis, as well as other drugs. Xenapax, which is interleukin 2, has been removed from the market. Anakinra, which is interleukin 1, is very promising. Interleukin 6, Actimra, is being investigated with very good results. Rituximab, which is anti-CD20, this is a marker on B cells. This would cause removal of all B cells in the body except the most mature plasma cell, and this is has been found useful in lymphomas as well as in corneal melts and cicatricial pemphigoid. So what's the current role of anti-TNF? In 2014 ophthalmology journal, the ophthalmology experts have came to a conclusion that infliximab and adalimumab, which is Remicade and Humira, can be considered as a first line in BASIT or a second line in other uveitis associated with juvenile arthritis, or in other uveitis if the patient cannot tolerate the immunosuppressor, is not effective. We should note that we very often add methotrexate and steroids to the anti-TNF therapy. So the reason why we're using this is that it reaches the target of inhibiting uveitis without a lot of collateral damage, without a lot of side effects. So what's the future? New therapies is in preparation. Immunotolerance has been wished for since a long time. It's not clear if they are going to achieve anything with it. Intravitreal route like Ozurdex and others like methotrexate and anti-TNF injections being studied. New biologics and the new signaling pathway called JAK-STAT. This is a new exciting discovery, and they're trying to target this pathway. Thank you. Are you still with me?
Yes, thank you, Dr. Abdel. Do we have any questions from the attendees? Okay.
I have my second presentation.
Okay, go ahead.
Before Dr. Terese. I know it's a little dry, you know. Okay, my second presentation is a rational approach to management of chronic uveitis. As you all, this is based on a paper since '97 in British Journal of Ophthalmology. And the presentation given by Dr. Dina earlier has given us a broad view of what's the anterior, intermediate, and posterior, which cases that you need to treat systemically, and which you can go with topical and so on. In this presentation, I'm going to give you a very simplified scheme of what to do when you're confronted with a uveitis patient, basically. You need to ask yourself three questions. Is this patient, is this uveitis infective or non-infective? Is it idiopathic or is it a part of the systemic disease? Is it anterior or posterior? Or the first question, is it infective or non-infective? We reach this mainly by clinical examination, not by investigation. We only do lab investigations to ensure or to confirm our doubts about certain etiology, like TB, toxoplasma, toxocara, CMV, herpes simplex, herpes zoster, as Dr. Adina previously showed us. Here, specific antimicrobial therapy is necessary, and immunosuppression can be very harmful. This is example of toxoplasma. This is, as Dr. Adina showed us earlier, in necrotizing hepatic retinitis and CMV retinitis, TB choroidal toxocara. The second question, you need to ask yourself whether this is only a uveitis located to the eye, or is it a part of a systemic disease? So about 50% of cases, it's only in the eye. However, sometimes it's associated with systemic disease, as previously mentioned. It can be part of MS, like as in pars planitis and vasculitis, for instance, sarcoidosis, Wagner's disease. Here, treatment should be tailored to both treat the systemic and local disease. And you should note that the activity of the ocular disease has no relation to systemic disease, which means that you can have a very active ocular disease with no systemic inflammation, and the opposite is true. These are examples, AMPI. However, very rarely it can be associated with a systemic disease, but in general, it's a localized eye disease, sympathetic ophthalmitis as well. Other conditions like Harada, for instance, often associated with systemic disease, as Dr. Adina has previously told us. It can be associated with neurological and skin manifestations. Intermediate uveitis, it can be located only to the eye, and here we call it pars planitis, which means it's not associated with systemic disease. Or it can be a part of a systemic disease like MS, sarcoidosis, and so on. Vasculitis, again, there is idiopathic vasculitis, or it's an idiopathic systemic vasculitis of no clear cause, or it can be part of Behçet, for instance, or sarcoidosis. Here, a typical example of Behçet's disease. You should note that disc and macular edema is an important sign in posterior uveitis in general. The presence of, in all kind of uveitis, anterior, intermediate, and posterior, you can have disc and macular edema, the presence of which indicates the disease is severe and you need to interfere. The third question, whether this condition is an anterior uveitis with some spillover into the posterior segment, or whether it's a posterior uveitis. These are two different diseases altogether. Mostly anterior uveitis is acute self-limiting that responds rapidly to treatment, and even the pathology, the immunopathology, is mediated by MHC1, CD8 type of reaction, whereas posterior is chronic, relapsing, progressively damages the vision, and is mediated by major histocompatibility antigen 2 with CD4 kind of reaction. However, there is a lot of overlap between the two sometimes, as in juvenile idiopathic arthritis, and also in juvenile idiopathic arthritis, the anterior uveitis is chronic, so you have to manage it with systemic treatment rather than topical treatment. And sometimes the anterior uveitis is acute and self-limiting, but it's so recurrent and is associated with the systemic disease, as for instance, seronegative arthropathies. And here you need to, again, to treat both the systemic disease and the eye disease with a systemic treatment. And this is the two different type of interaction. And this is a hypopion, often associated with BASIT or seronegative arthropathies. When we are planning the therapy, which is the next station, we need to ask ourselves two questions. Is immunosuppressive therapy necessary in this case? We're talking, of course, about a patient that we've excluded infection, of course. Is immunosuppression here, is therapy is here necessary? And whether the patient's general condition can tolerate this treatment. The reason why immunosuppressive therapy is not widespread in general is because of its side effects, the lack of experience. Most of the doctors don't have a lot of experience with it, and the false failures, which means that a lot of time we give the immunosuppressive therapy and we do not find an improvement of vision, so we conclude that it's not been effective, whereas we were looking for a control of inflammation rather than improvement of vision. And often we start the treatment too late in the disease when no improvement is expected. And then we, being afraid of the side effects, we tend to taper it too quickly. And these are the reasons why we fail with this with this treatment. So the next station, you need, once you decide that we are considering the immunosuppressive therapy, you need to ask yourself what to treat and when to treat it. So what to treat, as Dr. Adina has just told us, that the signs of inflammation is vitritis, choroidal vasculitis, disc and macular edema. The severity of these signs would determine the type of therapy. So these are multifocal choroiditis, serpiginous, toxoplasma, vitritis, vasculitis, different form of vasculitis, disc and macular edema. And according to the severity of these signs, you can classify or grade your uveitis into minimal, mild, moderate, and severe. This is not a universal classification. Each hospital has its own kind of classification or grading. And the next question is when to treat, according to how threatened is vision, or how much affection is already, how much damage has been done to the vision. And accordingly, you can consider the threat to vision is either remote, possible, probable, or likely. So if you have, for instance, a choroidal retinitis or serpiginous choroidal retinitis is very close to the fovea, this means that the threat is imminent. Or if it is a very severe wax rippling vasculitis, again, you need to quickly interfere. Accordingly, the decision to immunosuppress is you need to choose the appropriate therapy, and you choose how quick do you want to achieve this immunosuppression. If there is a very quick need, You need to think of intravenous methylprednisolone, for instance. If there is no quick need, then, and there is a need, you can use a less fast acting drugs. So the next question, if you remember, whether the patient's condition can tolerate this treatment, you need to do some basic investigations, as you can see. Once you understand that this patient needs the treatment and that the patient's condition can tolerate the treatment, and that you have now a baseline examination and investigation, and as Dr. Adina just said, you have registered or you've written down all the findings so that you can have a reference in the future whether this patient is getting better or you need more immunosuppression, you need to change the treatment. Once you're all set, you start the treatment. So as in the previous presentation, I've shown you the kind of drugs that we use. The most important drug that we have up till now is steroids, of course. And however, the problem with steroids is that we can't go for a long period on more than 10 milligrams because of its serious side effects. And 10 milligrams is not enough for more than moderate, mild uveitis. If it's moderate or severe uveitis, you cannot go on a single agent. You cannot go on 10 milligrams steroids. You have to add a second agent to the steroids. So if you want a rapid immunosuppression, then you go with intravenous drip of methylprednisolone. If you don't need very quick, then you can go with oral, which is 0.5 to 1 milligram, and rapidly taper it to 10 milligram as we discussed. Or if it's a unilateral idiopathic moderate disease, you can go with orbital floor steroids, long-acting steroids. For long-term control, you need other drugs, as we've discussed earlier. Cyclosporin and azathioprine are our cornerstones. If the disease is severe, you go with cyclosporin. If the disease is not that severe, you can probably go with azathioprine. And you should note that the effect is not produced before 14 days. So this is the period where the steroids can cover. And the aim with these drugs is to maintain control with the least side effects and for the long periods. Our regimen is cyclosporin 5 milligrams per kg per day in 2 divided doses to be tapered later on to 2 to 3 milligrams, and azathioprine 2 milligrams, 1 to 2 milligrams per day in 2 divided doses. We usually give just 100 milligrams, 50 in the morning and 50 in the evening. Added to the steroids as we've mentioned earlier, 10 milligrams or less. Sometimes we need to go with triple therapy because with steroids and cyclosporin, for instance, the disease is not controlled yet, so you have to add azathioprine or Celcept, or because the cyclosporin is causing nephrotoxicity or hypertension, so you have to go down with the other drugs. So with low doses of 3 drugs, you can achieve the immunosuppression you want. Sometimes the disease requires a slightly different immunosuppressive drug. For instance, methotrexate is very often used for juvenile idiopathic arthritis and rheumatoid arthritis because it's well tolerated in children. Cyclophosphamide is especially used in ANCA-positive vasculitis up till now. Sometimes if the disease is slow, you can, and it's not very severe, you can go with only one drug as a steroid sparing drug, as Celcept alone or methotrexate alone or azathioprine alone. So what's to do next? Once you've started the treatment, you're expecting adequate control in 3 to 6 weeks. So you need to watch the patient. You have your baseline examination and investigation. And then you need to, once you have achieved this control, you need to taper your steroid to 10 milligrams or less. And then you start tapering your cyclosporin next to 2 to 3 milligrams or even less. This is for months or years. The current role, as we've mentioned earlier, for anti-TNF is it can be considered as a first line basic. It can be considered a second line in particularly in children, juvenile idiopathic arthritis, and in other in other uveitis if the immunosuppressants are not effective enough or the patient is intolerant to them. We often add methotrexate to the Remicade or Humira. Once we've done that, we need to monitor two things. We need to monitor the progression, the eye condition, basically. So, and we need to monitor whether these drugs are causing any side effects. So it's a job for an ophthalmologist for the eye, and the job for the rheumatologist or the immunologist for the taking care of the drugs not causing any problem. So visual acuity should be assessed in every visit, both subjective and objective sometimes, like visual field. Objective assessment of the level of intraocular inflammation, anterior chamber activity, cells and flare, as Dr. Dina just said, fresh KPs, BIO score, the vitreous haze, anterior vitreous cells, assessment of areas of choroidal involvement and active vasculitis, both clinically and with fluorescein angiography, evaluation and severity of macular and disc edema, both clinically, OCT and fluorescein, as Dr. Terese will discuss in the next presentation. The next issue is monitoring the therapy. We need to see the patient in 2 weeks until control is achieved, and then 4 weekly intervals once we've reached stability. After 3 months of recurrence-free, then we try to stop the treatment very, very gradually. This is the job for the internalist or the rheumatologist. Knowing the side effects of each drug, you need to monitor each drug for the known side effects, noting that cyclosporin has a lot of interactions with other drugs, and it's nephrotoxic, and it can cause hypertension. Anti-TNF drug, the most important side effect is infection. You should be very, very careful with that. We need to check whether the patient has TB or latent TB before we go ahead and start treatment. At each visit, you need to inquire about side effects, even as an ophthalmologist. You need to perform lab investigations, avoid drug interactions, avoid combining drugs that are immunosuppressive. Thank you. Now, our next presentation is Dr. Terese. I'm not sure if she's still with us.
Dr. Azim, may I interrupt you? You know,
Sure.
we promised people that this is going to be interactive. So can I ask you a question, and can I ask Dr.
Sure.
Terese a question?
Sure.
All right. So you mentioned in your talk that you work with an internist. So do you work with an internist on everybody, even if there's isolated ocular inflammation, or do you do your own immunosuppression when it's only an eye disease, and you refer to a rheumatologist when there's confirmed systemic co-inflammation?
Okay. When I was still a senior house officer in the Uveitis Center, I was taught to have an internist with us all the time. Only cases of uveitis, which basically doesn't require except topical treatment, that will not require an internist opinion. The reason why I ask for the immunologist or rheumatologist opinion, even in cases like MP, for instance, if not MP, anyway, in a local disease where I'm going to use an immunosuppressant, because even the most safe of drugs like azathioprine is known to cause hepatotoxicity of not dose related, just idiosyncratic response. So I'm not really good in dealing with that. And I found it very patient caring to do that.
Okay. So I think the message that you're trying to convey is, if you're not if you're not trained to do your own immunosuppression and monitor those drugs because they're serious drugs, you would recommend working with a rheumatologist, right?
I would do definitely, unless you're going to use only steroids, which is okay. Otherwise, you need to take in a rheumatologist with you.
Okay. So, Dr. Teresa, I know you do your own immunosuppression in cases of isolated uveitis, right?
Yes,
Okay.
if I have a case that's isolated and we've done all the workup and nothing is coming up that shows
Positive.
it's a systemic condition, I would go ahead and start my medications, and I would monitor the patient according to the type of immunosuppressant I'm using with labs. However, if the patient is not responding sufficiently, and I have to add another immunosuppressant or probably sometimes switch to biologics, at this point, probably I need the help of an immunologist.
Can
Okay,
I have
good.
a follow-up question?
Sure.
Well, part of the physical assessment is a physical examination. It's not just labs. I mean, you need to listen to the chest of the patient, for instance. You need to see the whole body for skin rash. You need to test for hepatosplenomegaly, things like that. Arthritis, not all arthritis. We can, the arthritis dance, something that they do to see which joints are affected. So we're not experienced with that. I used to be inside this in Aberdeen in Scotland, but I can't do it on my own. It's very difficult. They used to ask me to do physical examination, neurological examination, and I used to do it, but not in my practice. I can't do that anymore. I can't do a full body examination, neurological examination, and so on. I'm not sure. Does Dr. Terese does that?
I think what Teresa is trying to say is that in the review of systems and in the workup, if there's nothing that's pointing
It's
to
showing up,
that's pointing to a systemic,
Yeah.
then it's isolated ocular until something else comes up, like the
Oh,
patient I
something
showed who
super.
had the granulomatous uveitis, and then you could. That's what you meant, Teresa, right?
Yeah.
Okay.
I have a question for you, Teresa, though. This was my follow-up question to you. If you're doing your own immunosuppression, do you start with low dose? So if the dose are, for example, azathioprine 2 to 3 milligrams per day, would you go at higher dose and then once you hit the ground running, you reduce the dose, or do you go up the ladder? Like you start with 2 milligrams per kilograms and then go up if it's not working.
Well, what I do is, because usually when I have decided that the patient is going to be on immunosuppressants, usually the patient will start with a high dose of steroids, and I'm concerned that the patient should get severely immunocompromised if I have both on high doses. So what I do is we start a high dose of steroids with low dose of immunosuppressants, and as I taper the steroids, I would start increasing the immunosuppressants. And if
Yeah.
this patient is stable for from 8 to 12 months, at this point, I would start decreasing the dose of immunosuppressants to very low doses and just check if this patient is going to relapse or not, just to know when I probably can stop the immunosuppressants.
Good. And I think also you meant once the immunosuppressant, the steroid sparing immunosuppressant has taken the role of immunosuppression in that patient, you reduce the steroids, right?
Exactly. Yeah.
Yeah. Good. I think we have a question for Dr. Azim. Do you use systemic anti-TB drugs in TB posterior uveitis with no pulmonary signs?
Most definitely. If quantiferol gold test shows up positive, this means that there is a latent TB, and it's presumed ocular tuberculosis. We don't have a definite proof that the uveitis present in the eye is because of the TB, but we have to go give a full course of antituberculous treatment anyway. But don't forget to add steroids as well. You can't go with this alone. You can go with the antituberculous treatment alone. You need to add the steroids as well.
I agree, and Therese, do you agree?
Yes, I agree. I'll go with 4-drug therapy with the steroid.
Good. So I think we all agree that you should use a pulmonologist on this job, right? Don't give anti-TB treatment on your own.
No.
Use a pulmonologist.
Use a flexible one, because if he doesn't find anything in the lungs, probably he's not going to be convinced this is TB and he's never going to give the treatment.
Absolutely be adamant about your diagnosis.
But there's another problem is that even if you wanted to give antituberculous treatment, you cannot, because it's not present in any pharmacy.
Yeah.
So you have to go through the pulmonist, the pulmonary guy. Yeah.
All right, excellent. I think we're ready for Dr. Kamal's presentation.
Can you work your video your video, Dr. Terese? Is it not working? Yes. No, it's not working.
I don't think so. No, it's not. But can you see my presentation?
Yeah.
Yes. Okay. Let me just clear it. So I'm glad to be with you all here today. Thank you, Dr. Azim, for coordinating this nice webinar. I'm going to start with a case, and this is of a 23-year-old female patient came complaining of visual field defect in the left eye that started 3 weeks earlier with mild ocular pain. Her review of system was unremarkable, but she had a family history of MS. Her cousin had MS. The eye that she was complaining of had a vision of 0.6, and anteriorly she was free. And this is the visual field that she had done a few days earlier, and we can see a large blind spot and inferior visual field defect. Looking at the fundus of this patient, both eyes, both left and right, look quite similar, except for mild changes in the fovea of the left eye that she was complaining of. So there was a question. Do we see her poll questions, Doctor? Poll questions.
Sorry.
Do we have the poll questions, or are we going without the poll?
Yeah. You want me to?
If it's possible, yes.
Yeah, sure.
So the question is here: what would you recommend next for this patient? I'm sorry. Would you do a VP autofluorescence, a fundus fluorescein angiography, or an MRI brain?
Okay.
Is it working?
Yeah, it's 64% fluorescein angiography.
Okay.
14% autofluorescence, 21% brain MRI. No one asked for VEP.
Okay. So this patient had a fluorescein angiography. Okay, nice. Thank you. Okay. So this patient had a fluorescein angiography that just showed this point hyperfluorescent lesions in the eye that was affected supratemporally. Actually, autofluorescence of that eye showed a very remarkable appearance pattern that we commonly see, and it shows the posterior pole glowing with hyperautofluorescence and the multiple red-like lesions that are present spreading through to the mid-periphery in the eye that was affected. And this is the condition that we all know as being mute. Sorry, I don't know what. I hope my, okay. So mute is multiple effervescent white dot syndrome, and this is another patient. This is a male patient, middle-aged male patient, who also had mute, and we can see because you can see how the posterior area are mainly affected by this hyperautofluorescent lesions, and the smaller red-like lesions are spreading through to the mid-periphery. A very good tool that you'd use apart from autofluorescence is the OCT and the InFAS imaging that you would find on your OCTA machine if you have one. And what we see in mute is disruption of the outer layers, that is the ellipsoid and external limiting membrane, as we can see temporally. And the InFAS image of this area would show hypo-reflective pattern, while the area that shows just mild restored or preserved outer layers would show a relatively iso-reflective appearance. And these are localized areas, and they usually are multifocal. As the patient goes through healing, which is a spontaneous condition of healing, we can see that these lesions that are seen in the red circle correlating with the blue one, the blue circle here, as the outer layers start to be restored, and we can see that the ellipsoid zone and the external limiting membrane are back restored, and the hyperreflective appearance on InFAS imaging at this region, which is the ellipsoid zone, is starting to give the iso-reflective appearance once more. And this is 1 year after the patient got treated, healed, and we can see that the patient has restored a normal OCT appearance and likewise the InFAS of the ellipsoid layer. And this is the autofluorescent appearance of this patient, and we can see that all the lesions that we had seen earlier have completely disappeared. And this patient, right from the start, the choriocapillaris by OCT angiography didn't show any kind of involvement. So this would take us back to literature when mute was debated to be an insult of the choriocapillaris, and they highlighted this by ICG. Now they are saying it is a photoreceptor damage, and the choriocapillaris actually is not involved, and they are referring to it as photoreceptoritis. As we can see, the photoreceptors damage and then back to normal. So MFAS imaging is an important tool apart from autofluorescence, and it would show you when the patient is in an attack and in recovery, and OCT angiography didn't show any involvement. This is the first patient that had the visual field effect, and we can see through the different stages she got back her MFAS appearance in the ellipsoid layer. You can see through autofluorescence how this patient was doing quite well, and the visual field also improved. But the patient was still complaining, which was very awkward because everything seemed quite normal, and mute is a self-limiting condition. So another autofluorescence actually showed that this patient was starting to develop lesions, which is quite unusual for mutes. In cutting through this lesion in the early stages, you could see the inflammatory aggregates and disruption of the outer layers, and then eventually it atrophied completely, and we can see the RPE has thinned out, and you can see the increased reflectivity through this layer. And the size of the lesion actually increased, and the number of lesions also increased. And there seems to be the simultaneous occurrence of mute with multifocal choroiditis. And so when you have a patient with mute, and we all know it's a self-limiting condition that will go without treatment, be careful to watch out for your patient, because occasionally these patients may start to develop a multifocal choroiditis that actually can be vision depleting. Another patient again came with this leaky lesion in the superior parafoveal area, and by OCT and fluorescein we can see that this is a frank CNV. But why would this occur in a patient who is in arthritis? Having an autofluorescent, again we can see how nicely it has highlighted that this is a patient with mutes, and in true healing we can see all the lesions have disappeared again, and OCT angiography would show you the active lesion being a CNV with areas of flow void, and again after the patient had an anti-VEGF injection, the regression of the vascular front has started to occur into mature vessels. So interestingly, after they had already decided that this we have
Terese? Oh,
you can't hear me.
Breaking up. Now
okay.
You can.
Okay, good. So they said that the occurrence of CNVs in patients with mutes could occur due to a limited ischemia that would occur at the level of the choriocapillaris and the
Voice is breaking up again.
I don't know why. Okay.
All right. Try now.
Okay, good. So a fourth case is a patient who is myopic, and she comes with a CNV that we can see both by fluorescein and confirmed by fluorescent lesions.
I think there's something wrong with your microphone. Could you try and
Okay. Is it better?
Yeah. No, that's better.
Okay. So by autofluorescence, we can see that there are multiple lesions scattered all through the posterior pole.
Okay. I'm sorry to interrupt again.
You can hear? There's a problem with the sound?
Yeah.
Okay.
It's muffled and sometimes it breaks up.
Can you hear me?
We can now.
Okay, is this better? Okay. Yeah. So multifocal choroiditis or PICS, these are two types, two subtypes, like two.
Okay, we don't want to miss this valuable lecture. Do you mind trying to plug or unplug your microphone or actually lose it, use the computers?
I think it's a problem with the net rather than the microphone.
Is it better now?
Well, it comes and goes, Teresa. It keeps breaking up. Can you use the computer microphone?
Is it better now?
Yes,
Oh,
excellent.
much better.
Okay. So as I was saying, what we would see if you had an OCT cutting through one of these lesions in the early stage is a small RPA elevation. It might not show on fluorescein. By OCT through the choriocapillaris, you could see small dark spots or flow void. And by in-fast imaging in that area, you can actually see very nice delineated pictures of these small early lesions. This is another case, a patient also with PICS and CMV who is myopic, and you can see a complete mature lesion. We can see a large nodule breaking through the RPE, going into up to the inner plexiform layer, and also has an extension into the choroid. By OCT angiography, we can see again an area of flow void. And we can see this flow void setting the slabs over the choriocapillaris. You can see that actually this is an area of ischemia with the trail that we commonly see, an area of infiltration of the inflammation into the choriocapillaris that would affect the flow, that would appear as an area of flow void, and we can see the trail beyond this nodule. This is another patient, and this patient actually showed a very small lesion temporally that increased in size, and at this point she was active, and at this point this lesion had atrophied. And by OCT angiography, we can see actually that this patient had a small area that showed, here you can see the infiltration of the choriocapillaris that appears as flow void, and here you can see the ischemia of the choriocapillaris or atrophy that again appears as flow void. Autofluorescence again is another very important tool that can help you know if you're treating your patient effectively. And this is a patient with multifocal choroiditis, shows on treatment. And actually she had a few lesions in the infranasal area, so we started treatment. And then she came in 6 months because she had missed a few of her follow-ups. And we see that she's extremely active. Not only had the lesions increased in number, but also increased in size. And a very typical appearance of active lesions is a small hypo-autofluorescent area surrounded by a rim of hyper-autofluorescent, denoting that the RPE is actually getting into an insult and eventually will damage, and this lesion will widen. Means you're not controlling your patient effectively. This very same patient also came with a CNV in that visit, and we could see it in the OCT angiography slabs and confirmed by OCT. And you can see the typical pitchfork sign, which are inflammatory aggregates over the CMV into the inner layers, and it is quite characteristic of inflammatory CMV. So whenever you have a patient with uveitis, be it PICS or multifocal choroiditis or VKH, who is developing a CNV, it means you're not controlling your patient effectively. Choroidal new vessels actually in patients with PICS or multifocal choroiditis were underestimated before the use of OCT angiography, and over 10 years we could see a 4-fold increase in the percent of patients who have CNVs in multifocal choroiditis, meaning that some of the lesions that were seen before OCT angiography were thought to be inflammatory lesions, but actually were CMVs, and this were better appreciated by OCT angiography. Patients with PICS or multifocal choroiditis would have a typical sprouting or creeping pattern of CMVs, unlike those that you would see in myopic patients or AMD patients, where you have the vessels sprouting out and joining in confluently with nearby lesions or areas. This is the fellow eye of the patient who had the CNV, and she came in one of the visits and she complained that she had developed a severe visual field defect in the eye that had already poor vision. And it was quite surprising because I knew she couldn't appreciate well vision with this eye. So we had an autofluorescence that showed remarkable washout of the RPE or insult of the RPE over a very wide scale of the posterior pole. And this was described earlier in 2015, where in patients who had multifocal choroiditis developed acute or subacute photoreceptor loss or dysfunction. And this was thought to be due to accumulation of fluoropores within the RPE. Some patients would recover, and some patients would not recover. Actually, my patient didn't recover. Another patient is a patient who is a 36-year-old female, came with bilateral paracentral scotoma after a car accident that occurred 3 weeks earlier. She had a review of her system, which was unremarkable, a vision of 0.8 and 0.9, and anterior segment exam was unremarkable. Looking at the infrared images of both eyes, you could see this wedge-like or droplet-like lesions in the parafoveal area that explains why this patient had paracentral scotoma. And cutting by OCT through these lesions, you could see hyperreflective appearance of the outer plexiform layer and inner nuclear layer. And actually, this very typical characteristic appearance, which is best appreciated by infrared imaging, is known as acute maculopathy with neuropathy, or AMN, and it is explained to be a form of ischemia of the deep capillary plexus. This patient actually had started to heal. I would show you a more acute stage of this lesion. Let me just first describe that you would see the outer plexiform layer thickening, and this would involve the outer nuclear layer as well, and the ellipsoid layer and the external limiting membrane would start to show attenuation or occasional loss. This is another patient, but in the active stage, and this is typically what you would see, an area of hyperreflectivity and disruption of the photoreceptors of the ellipsoid and external limiting membrane. Through healing, this patient would start to develop thinning of the outer plexiform layer, attenuation. Sometimes the ellipsoid layer would start to restore back, and the external limiting membrane would start to restore back. Occasionally, it may remain attenuated, and the paracentral scotoma typically would fade away within 4 to 14 weeks, and sometimes it might leave residuals. This is the OCT angiography of the patient who had the car accident, and we can see that the superficial plexus looks quite unremarkable. However, because this patient was in the healing stage, I believe, so maybe if you could see this slightly hyporeflective appearance correlating very nicely with the fast imaging of the outer retinal layers. The outer retinal layers would show the silhouettes of the hyporeflective lesions still present, though the patient was in the healing stage. And so why is the deep capillary plexus an area that is threatened by ischemia? Or why do the patients start to have some visual defects when this occurs? This is because the outer plexiform layer is mainly composed of photoreceptor exon terminals that depend mainly on deep capillary plexus for oxygenation, and because there is a decrease of diffusion of gradient of oxygen from the choriocapillaries to the photoreceptor axon. So it's like a watershed zone or a weak area. So once a patient starts to experience some form of ischemia, the deep capillary plexus is actually threatened. It's more common in patients who have either vascular problems, some sort of vasculitis or vasculopathies, in patients who are caffeine addicts, and in patients who are use oral contraception. It has been described in people who have had non-ocular accidents or trauma. This is another patient. This is a patient, he's a 25-year-old male patient, and these pictures were taken by Dr. Shaima Ibrahim. This patient came complaining of decrease in vision in both eyes that occurred simultaneously, and he shows multiple placoid lesions scattered all through the posterior pole in both eyes and a small superficial, a pre-retinal hemorrhage in the right eye. By autofluorescence, you could see mainly hypoautofluorescent lesions and few hyperautofluorescent lesions seen in the supratemporal area. This was actually less appreciated maybe in the fellow eye, but we can see also the areas of hyper and hypoautofluorescent appearance. Fluorescein angiography delineated the areas that showed the hypofluorescence more evidently than the OCT, than the autofluorescence, I'm sorry. And in the late frames, we could see that the posterior pole still maintained some of the hypofluorescent lesions in the right eye. However, the left eye started to show some sort of isofluorescent appearance. And this is a condition known as acute posterior multifocal placoid pigmentary epitheliopathy, which is also known as MP. And the question of debate is it a condition that affects the choriocapillaris in form of inflammation or ischemia, or is it an epitheliopathy as it has been named? This patient had an OCT angiography that showed at the level of the choriocapillaris multiple placoid lesions of hyporeflectivity in both eyes, better appreciated than the autofluorescence and the fluorescein. OCT through these lesions showed the presence of insult of the choriocapillaris. This is not the normal appearance of the choriocapillaris with thickened choroid, disruption of the RPE layer, and inflammatory aggregates mounting into the inner layers in both eyes. This patient actually was sent for imaging and didn't show up again. But one of my patients who had come to me had MP, and this was the picture. I'm sorry for the quality of the images, but she had it in her, kept in a file. It wasn't well preserved. So this was the only picture I had that would tell me this patient was an MP patient. When she came to me, she was in the healing stage, and we can see that the autofluorescence hardly shows anything in the right eye except for a few lesions here, while the left eye still showed some hyper-autofluorescent lesions, which would be the case if a patient had MP and it's starting to heal. OCT and geography didn't show much in the right eye, but the left eye actually showed areas of flow void that correlate with hyper-autofluorescent lesions. This patient showed a quite decent OCT in the right eye. However, the left eye still showed some damage that could be seen in the outer layers, and we can see areas of attenuation of the choriocapillaris in both eyes. This patient came 3 months later. She had improved, then started to relapse again. And we can see the left eye that had showed some lesions starting to do very well, while the right eye is starting to show some lesions again. And we can see here that we have a small area of flow void, and we can see the amount of ischemia in the choriocapillaris. The fellow eye, however, that had these lesions earlier started to show restoration of the choriocapillaris. The supranasal lesion to the disc actually showed involvement of the choriocapillaris, disruption of the outer layers overlying it, and also it showed some areas of flow void by OCT and geography. So MP, the pathophysiology of MP is believed to be hypoperfusion of the choriocapillaris being the primary event, while what the RP and the outer retinal pathology occurs secondary to the localized hypoperfusion resulting from these inner choroidal changes. And this is the second poll question. So this is a patient who is 16 years old. He came in with this appearance, and he said he had a decrease in vision over the last 1 month. And the vision was 0.05 and 1.0. And whenever you see this appearance, what would you like to ask this patient about? This is a poll question. Would you like to ask about flu-like symptoms, chest manifestations, laser pointer exposure, or photopsia?
I really wish I could take part in this poll. Apparently can't.
Well, you can tell us what you were thinking later.
Yeah, true.
Okay, can we have the answers?
45% flu-like symptoms.
Okay, the answer here is that this is a laser pointer. So
I wanted to say it.
Yes, I knew you were going to say it. Okay, you can see two small lesions here. These are lesions that would make you suspect that this patient was exposed to a laser pointer. And you can see this trail, which is very unusual for any inflammatory lesion that we know about. The patient actually had been exposed to laser pointer for quite some time into the eye, mainly the right eye, and this is what caused this appearance. Okay, so my final slide is the take-home message, and I would just like to convey the message that proper understanding of the pathophysiology of different uveitic entities can enhance proper use of the appropriate multimodal imaging techniques. These machines are all over the place, and we can play with them and find out more about the diseases we're treating. And whenever you have a clue, you can know which kind of multimodal imaging you would use for that kind of disease, and this would help you actually diagnose, follow up, and effectively manage your patients. Thank you.
Thank you, Dr. Terese, for a very enlightening presentation. So you use it a lot, autofluorescence.
Yeah, we use multimodal imaging. This is what we do. We try and check on our patients the different types of imagings for every disease entity, and this would give you. So if you're suspicious of one disease, like in the OCT of the patient with mute, then you would go ahead and do the autofluorescence, and this would give you a better image of what you're seeing. Then you go ahead and do the in-face imaging, and this will also help you follow up the patient. So like a patient who has mute, you know, probably this patient is going to be self-limiting. Patient with multifocal choroiditis, you need to know where you're starting, where treatment is taking you. Is it effective enough? Is it not effective enough? Am I over-treating or under-treating? So it's like, these are the toys we play with, actually.
Okay. So
I have a
autofluorescence, sorry,
Yeah,
autofluorescence, you use it in many instances with patients with multifocal choroiditis to try to determine at what level is the inflammation, and to consider following the patient up, whether the treatment is effective or is healing or not, and so on.
Yes.
Okay.
Okay, Dr. Teresa, and you know, most of our patients are out-of-pocket pay patients. If you're going to recommend 1 or 2 maximum images on each on a patient for our attendees, what would you recommend?
I would.
You know, you have two tops.
Okay, but it depends on what you're thinking about. So if your patient comes in with vitritis, I mean, this patient has very dense vitritis, and you're not sure if he has vasculitis, probably you'd like to have a fluorescein. If the patient has this granular, it depends on what you're seeing. If you have a patient who has like visual field effects and a granular fovea, you would go for autofluorescence probably. It depends on what you're seeing. That's how it goes. I mean, I can't really just say we're going to use this as an epsilon factor, or that depends on what you're seeing. You have to correlate it.
All right. Okay, thank you. Okay, do you have any questions from the attendees?
Thank you, everybody, for bearing with us this difficult subject. We have still 2 parts to go next week and the week after. And it's going to get a little bit more clinical as we go. And hopefully this would be interesting, inshallah. Thank you, Dr. Dina. Thank you, Dr. Terese. I hope everybody had fun.
Thank you, Doctor.
All right, thank you.
It's been a pleasure. Thank you.